Every year, tens of thousands of seniors are discharged from emergency rooms across the United States, having been told they have a stomach bug, an inner ear infection, extreme dizziness, or food poisoning, when what they actually have is a brainstem stroke. The brainstem is the most critically vital region of the entire brain. It controls breathing, heart rate, blood pressure, the ability to swallow, eye movement, consciousness, and the transmission of every signal between the brain and the body. A stroke in the brainstem, a blockage or rupture of the blood vessels supplying the midbrain, the pons, or the medulla oblongata, is one of the most dangerous medical emergencies that exists, and it is the stroke that is most commonly misdiagnosed, most commonly dismissed, and most commonly missed by both patients and the physicians who first evaluate them. The reason brainstem strokes are so consistently missed is fundamental. Most people have learned to recognize strokes through the FAST acronym: face drooping, arm weakness, speech difficulty, time to call 911. FAST was designed to identify strokes of the anterior circulation, the front and sides of the brain, where most strokes occur. When a stroke happens in the posterior circulation, in the brainstem and the cerebellum, the presenting signs are completely different. The face may not droop. The arms may not be weak. The speech may be only mildly affected. What presents instead is a combination of symptoms that look and feel exactly like the inner ear, the stomach, the eyes, or a viral illness. A review published in Frontiers in Neurology, specifically examining posterior circulation strokes in the emergency setting, found that the standard National Institutes of Health stroke scale drastically underestimates the severity of brainstem strokes, meaning the most widely used emergency stroke assessment tool gives false reassurance when the stroke is in the brainstem. Nearly 39.4% of posterior circulation strokes do not fit the standard rapid stroke recognition pattern. Patients with brainstem strokes experience longer times from emergency department arrival to neurology evaluation than patients with anterior strokes, a delay that, in brainstem stroke, can mean the difference between recovery and permanent disability or death. Sign number 5 on this list is the one appearing in the left panel of this video's thumbnail, the one that sends more seniors home from emergency rooms untreated than any other brainstem stroke sign, because it looks exactly like a gastrointestinal emergency rather than a neurological one. Sign number 1 requires calling emergency services immediately, not an urgent care appointment, not a same-day GP visit. Write your age in the comments right now and tell us, have you ever experienced sudden severe dizziness that lasted for hours? We read every single comment. The brainstem consists of 3 sections: the midbrain at the top, the pons in the middle, and the medulla oblongata at the bottom. The medulla oblongata is where the brain connects to the spinal cord, and it contains the control centers for breathing, heart rate, blood pressure, swallowing, vomiting, and the regulation of consciousness. The pons, sitting above the medulla, contains the nuclei of many cranial nerves, the centers controlling eye movements, sleep, and facial sensation. The midbrain, at the top, contains the nuclei of the cranial nerves, controlling eye movement, and the pathways connecting the cerebellum to the rest of the brain. The blood supply to all 3 sections comes from the posterior circulation, the 2 vertebral arteries running up through the vertebrae of the neck, which join at the base of the skull to form the basilar artery running along the front of the brainstem. The entire posterior circulation supplies approximately 20% of the brain's blood. The brainstem, the cerebellum, the thalamus, and the occipital lobes, through vessels that are far narrower and more vulnerable to atherosclerotic narrowing and blood clots than the large carotid arteries of the anterior circulation. Posterior circulation strokes account for approximately 20% of all ischemic strokes, according to StatPearl's review from NCBI. Brainstem strokes specifically account for 10 to 15% of all strokes. Basilar artery occlusion, the most severe form of brainstem stroke, carries a mortality rate that has historically exceeded 85% without prompt treatment. Among seniors over 65, The risk factors that cause posterior circulation strokes are exactly the same as those causing anterior strokes: hypertension, diabetes, high cholesterol, atrial fibrillation, smoking history, and the progressive atherosclerotic narrowing of the vertebral and basilar arteries that accumulates over decades. A senior with high blood pressure and type 2 diabetes, who has never had a symptom suggesting a brain problem, is at exactly the same risk of posterior circulation stroke as anterior. But the standard stroke education they have received, the fast posters in their GP waiting room, the stroke awareness campaigns on television, none of these will help them recognize a brainstem stroke when it begins. The difference is that the symptoms these risk factors produce when they cause a posterior stroke are unfamiliar, easily dismissed, and specifically poorly captured by the standard stroke recognition tools that most emergency personnel are trained to use. The American Stroke Association and the National Institute of Neurological Disorders and Stroke in the United States clearly state that posterior and brainstem strokes can be more difficult to diagnose and often present with dizziness, sudden loss of balance, double vision, and decreased consciousness rather than the classic fast signs. Sign number 9. Sudden severe dizziness and vertigo, with no inner ear explanation. Dizziness and vertigo are the single most common presenting complaint of brainstem stroke, and they are the single most common symptom that causes a brainstem stroke to be misidentified as a benign inner ear problem and sent home untreated. An older adult suddenly gripping the edge of a countertop because the room is spinning uncontrollably, the floor seeming to tilt and shift beneath the feet. The sensation of being on a boat in rough seas while standing completely still on solid ground. A sudden inability to walk in a straight line because every step feels like the ground is moving sideways. These are the symptoms of acute vestibular dysfunction, and in a senior with vascular risk factors, they are a brainstem stroke until proven otherwise. The vestibular nuclei, the brain structures that process balance and spatial orientation signals from the inner ear, sit in the pons and medulla of the brainstem. When blood flow to these nuclei is cut off by a posterior circulation stroke, the result is acute vertigo that is clinically identical in its subjective quality to the vertigo of benign positional vertigo or acute labyrinthitis, common, harmless inner ear conditions. An older adult in an emergency department examination room, lying on the stretcher, the room still spinning 90 minutes after onset, a nurse handing them a prescription for meclizine and a note to follow up with their GP. The diagnosis written on the discharge paper, vestibular neuritis. The actual diagnosis, posterior circulation TIA, progressing to full brainstem stroke within 48 hours. This specific clinical scenario, acute vertigo discharged as inner ear, return within days with completed brainstem stroke, is documented repeatedly in the posterior circulation stroke literature. According to StatPearls, the prodromal symptoms of basilar artery occlusion in the hours to days before the stroke fully develops most commonly consist of vertigo and nausea. A study published in PMC on basilar artery occlusion syndromes found that dizziness and vertigo account for approximately 4 million emergency department visits annually in the United States, and that this volume of patients with dizziness creates a clinical environment where the small percentage who are having posterior circulation strokes are routinely missed. The specific clinical test that separates benign inner ear vertigo from brainstem vertigo is called the Hintz examination, head impulse, nystagmus test of skew. A physician performing the head impulse test in a patient with brainstem origin vertigo will find a normal head impulse test. The eyes do not correct with a compensatory saccade, which is the opposite of what occurs in peripheral inner ear vertigo. Any senior experiencing sudden severe vertigo, particularly with vascular risk factors, who cannot walk steadily, who has any additional symptom on this list, or whose dizziness appeared with any headache or neck pain in the preceding days, needs immediate emergency evaluation for posterior circulation stroke, not a prescription for meclizine and reassurance that it is probably an inner ear problem. Sign number 8. Sudden loss of coordination and balance, falling toward one side without feeling dizzy. An older adult walking from the kitchen to the living room and drifting involuntarily toward the right side, the right shoulder bumping the door frame on the way through. An older adult reaching for a cup on the table and the hand passing to the right of the cup instead of landing on it. An older adult trying to walk in a straight line and finding the body repeatedly veering in one direction, regardless of conscious correction effort. An older adult describing a feeling of being pulled sideways by an invisible force. These are the signs of cerebellar or brainstem ataxia, the loss of coordination and balance produced when the blood supply to the cerebellum or its connecting pathways in the brainstem is cut off by a posterior circulation stroke. The cerebellum sits behind the brainstem and coordinates the smooth, accurate execution of all voluntary movement. It receives sensory information from the muscles, joints, and balance organs of the inner ear and continuously adjusts motor commands to keep movement precise and balanced. When the posterior inferior cerebellar artery, the anterior inferior cerebellar artery, or the superior cerebellar artery is occluded by a blood clot, the cerebellum on that side loses its blood supply, and the coordination of movement on the same side of the body fails. The result is lateropulsion, a consistent falling or drifting toward the side of the cerebellar lesion, combined with dysmetria, the inability to accurately judge the distance and direction of a movement. In Wallenberg syndrome, the most common form of brainstem stroke, lateropulsion toward the side of the lesion is one of the most consistent early findings, documented in the Stat-Pearls review of lateral medullary syndrome as ipsilateral ataxia, with a tendency to fall to the ipsilateral side. An older adult who develops sudden inability to walk straight, sudden clumsiness in one hand, or a tendency to veer in one direction while walking needs emergency evaluation that same hour, because these are symptoms of posterior circulation stroke until proven otherwise. Sign number 7. Double vision, eye misalignment, or abnormal involuntary eye movements. Double vision, seeing two images of a single object occurring suddenly in an older adult, is a brainstem stroke until proven otherwise. The nuclei of the cranial nerves controlling all eye movement, cranial nerves 3, IV, and VI, reside in the brainstem. Cranial nerve 6 controls the lateral rectus muscle that turns the eye outward, and its nucleus sits in the pons. Cranial nerve 3 controls most of the other eye muscles and sits in the midbrain. When a stroke damages these nuclei or their interconnecting fibers, the eyes fall out of alignment. One eye may deviate inward or outward, while the other maintains its normal position. The result is diplopia, double vision that cannot be corrected by rubbing the eyes or changing lighting, and that appears and disappears without explanation. Nystagmus, rapid, rhythmic, involuntary eye movements, appearing suddenly in a senior is another critical brainstem stroke sign. In brainstem stroke, nystagmus is central in origin, beating in a direction that is inconsistent, can be purely vertical, and is not suppressed by visual fixation. This distinguishes it from the nystagmus of benign inner ear conditions, which is peripheral in origin, unidirectional, horizontal or horizontal rotary, and suppressed by visual fixation. Skew deviation, a vertical misalignment of the eyes where one eye is higher than the other, is a specific sign of posterior fossa lesions that almost never occurs in peripheral vestibular disease. According to the review published in Frontiers in Neurology on Pitfalls in Posterior Circulation Stroke Diagnosis, vertical or alternating horizontal nystagmus in primary gaze is of central etiology until proven otherwise, meaning it is a brainstem or cerebellar lesion until imaging shows otherwise. Any older adult with sudden double vision, sudden eye misalignment, or sudden involuntary eye movement needs immediate emergency neurological evaluation. Sign number 6. Slurred speech and difficulty producing words without the typical facial droop. An older adult whose speech has suddenly become thick, slurred, and difficult to understand, the words coming out blurred, the consonants losing their crispness, but whose face looks completely symmetric, whose arms are both equally strong, and who can understand everything said to them and knows exactly what they want to say. This is dysarthria from a brainstem stroke, a disorder of the motor control of speech production, and it looks completely different from the aphasia and facial weakness of an anterior circulation stroke. The speech sounds drunk. The individual letters are imprecise, but the sentence structure, the word choice, and the comprehension are intact, because the language centers of the brain are in the anterior circulation and are unaffected by a posterior stroke. Dysarthria in the context of brainstem stroke results from involvement of the nucleus ambiguus, the corticobulbar fibers, or the cerebellar connections in the pons or medulla that coordinate the precise muscular movements of the lips, tongue, palate, and vocal cords required for intelligible speech. It is present in approximately 30 to 63% of basilar artery occlusion cases, according to the MedLink Neurology Review. It accompanies dysphagia, the difficulty swallowing described in sign number 2, because the same nerves and brain structures control both speech production and swallowing. The specific warning for seniors, sudden slurring of speech in the absence of facial droop, arm weakness, or aphasia, is not reassuring in the context of a posterior stroke. It is a posterior circulation stroke sign that will score low on FAST, but is potentially the beginning of a life-threatening basilar artery occlusion. Sign number 5, unstoppable nausea, vomiting, and persistent hiccups, the most misdiagnosed brainstem stroke sign shown in this video's thumbnail. The left panel of this video's thumbnail shows what looks like gastrointestinal pathology, an enlarged mass near the pelvis and stomach representing the GI catastrophe that brainstem stroke mimics perfectly. An older adult developing relentless nausea, not the nausea that builds and then eases, but nausea that begins acutely and does not respond to any antiemetic, position change, or dietary modification. Vomiting that occurs repeatedly over hours, producing no relief of the nausea after each episode, in a way that is completely atypical of food poisoning or gastroenteritis, which typically improve over time. And hiccups, intractable hiccups that began at the same time as the nausea and cannot be stopped by any of the standard breath-holding maneuvers. This combination, severe nausea, unstoppable vomiting, and persistent hiccups arriving simultaneously, is the hallmark of area postrema involvement in a brainstem stroke, and it is the sign that is most reliably misdiagnosed as gastrointestinal illness rather than as the neurological emergency it actually is. The area postrema is a small structure in the medulla oblongata, the lowest section of the brainstem, that contains the brain's chemoreceptor trigger zone for vomiting. It detects noxious substances in the blood and triggers the vomiting reflex. When a stroke damages the area postrema or the adjacent lateral medulla, the vomiting center is damaged and produces uncontrolled, intractable nausea and vomiting that is completely resistant to standard antiemetic medications. A case report published in PMC documented a 62-year-old patient who presented with intractable nausea, vomiting, and hiccups from area postrema syndrome caused by an ischemic stroke in the cerebellum and brainstem. The case report specifically noted that ischemic brainstem stroke should be considered in the differential diagnosis for area postrema syndrome, and that a close review of imaging is critical because the area postrema is small and easily missed on standard brain imaging. The review in the journal Consensus specifically documented that in cases of ischemic brainstem stroke, vomiting can be the predominant symptom when other neurological abnormalities are minimal or absent, and that this leads to misdiagnosis as a gastrointestinal disorder with a hazard ratio for death of 5.06 for all stroke patients presenting with vomiting. The key clinical clue that distinguishes brainstem origin vomiting from gastrointestinal vomiting, the hiccups. Intractable hiccups occurring alongside severe nausea and vomiting. Hiccups that have been present for more than 48 hours continuously in a senior with vascular risk factors is a medical emergency. The StatPearls review of Wallenberg syndrome specifically states that hiccups can often be intractable, and that intractable hiccups combined with vomiting suggest a localized lesion in the area postrema of the medulla. The Science Direct review of area postrema syndrome due to medullary infarction confirms that intractable nausea, vomiting, and hiccups are the clinical syndrome of area postrema involvement in brainstem stroke. Any senior or any family member of a senior who observes the combination of severe persistent nausea with hiccups that began at the same time in a person with vascular risk factors must call emergency services immediately and describe all three symptoms together, because any one of them alone might be dismissed, but the combination in a senior is a brainstem stroke emergency. Sign number 4, one-sided eyelid drooping, a smaller pupil on one side, and reduced sweating on one side of the face, Horner syndrome. An older adult standing at the bathroom mirror and noticing that the right eyelid has dropped slightly lower than the left, a partial ptosis that was not there this morning. Looking more closely and noticing that the right pupil is smaller than the left, not dramatically, but measurably, visible in room light. A family member touching the right cheek and noticing it feels dry, while the left cheek is slightly damp from normal facial moisture. This specific combination, drooping eyelid on one side, smaller pupil on the same side, and reduced sweating on the same side of the face, is Horner syndrome, and in a senior with vascular risk factors, it is a lateral medullary brainstem stroke until proven otherwise. Horner syndrome results from damage to the descending sympathetic fibers that run through the lateral medulla of the brainstem. These sympathetic fibers normally maintain the tone of the muscle that elevates the upper eyelid, dilate the pupil, and stimulate sweating on that side of the face. When they are interrupted by a lateral medullary stroke, Wallenberg syndrome, the affected side of the face loses sympathetic tone, the eyelid droops slightly, the pupil constricts slightly, and the skin on that side becomes dry. An older adult looking at themselves in the bathroom mirror under bright overhead lighting, tilting the head forward to bring both eyes level, and noticing clearly that the right eyelid is resting about 2 millimeters lower than the left, a partial ptosis, not the full droop of a third nerve palsy, but distinctly asymmetric, in a face that was symmetric this morning. Looking at the pupils directly, the right pupil is visibly narrower than the left in the same room light. This asymmetry of eyelid and pupil, both on the same side, combined with any dizziness, any swallowing difficulty, or any sensory change, constitutes Horner syndrome from a brainstem stroke. Horner syndrome from a Wallenberg syndrome stroke is ipsilateral. It occurs on the same side of the body as the brainstem lesion. This is one of the features of brainstem stroke that makes it so diagnostically distinctive when recognized. The crossed pattern, with ipsilateral face findings and contralateral body findings, localizes the lesion to the brainstem specifically. According to the StatPearl's review of lateral medullary syndrome, Horner syndrome is one of the consistent clinical features of this most common brainstem stroke syndrome. Any senior who develops a new unilateral eyelid droop, pupil asymmetry, and any other symptom from this list on the same day requires same-day emergency evaluation. Sign number 3, numbness and tingling on one side of the face and the opposite side of the body, the cross-sensory sign of brainstem stroke. An older adult describing a tingling numbness on the right side of the face, the right cheek, the right side of the lips, the right side of the tongue, combined with a loss of the ability to feel the temperature of a warm shower on the left arm and left leg, the right face and the left body. Numbness on opposite sides of the face and body, happening simultaneously, is the pathognomonic cross-sensory sign of lateral medullary brainstem stroke, and it is a sign that is almost impossible to produce by any other condition. It is explained by the anatomy of the brainstem sensory pathways. The spinothalamic tract, which carries pain and temperature sensation from the body, crosses the midline in the spinal cord before ascending and enters the brainstem already carrying signals from the opposite side of the body. The spinal trigeminal tract, which carries pain and temperature sensation from the face, does not cross until it reaches higher brain structures. When a stroke damages the lateral medulla, it damages both tracts simultaneously, producing numbness on the ipsilateral face and the contralateral body. This specific pattern, called crossed hemianesthesia, is virtually diagnostic of a brainstem lesion when it occurs. According to the StatPearl's review of lateral medullary syndrome, sensory signs and symptoms are the most frequent manifestations of Wallenberg syndrome, present in 96% of cases. An older adult who notices that the warm water from a shower feels normal on the left side of the body, but cannot be felt on the right side, combined with tingling or numbness on the left side of the face. Left face, right body, is experiencing the crossed hemianesthesia of a right-sided lateral medullary infarction. An older adult drinking a hot cup of tea and noticing it is undetectable as hot against the right side of the tongue and the right side of the lips, while the left side of the mouth registers the heat normally, is experiencing the ipsilateral facial sensory loss component of the crossed pattern. These sensory discrepancies are subtle enough that many older adults attribute them to circulation problems, to diabetes-related neuropathy, or to having slept on their arm or face awkwardly. The specific quality that distinguishes crossed sensory loss from peripheral neuropathy is the simultaneous involvement of opposite sides of the face and body, a pattern that peripheral nerve damage cannot produce. This specific pattern will not appear in fast screening. It will not be detected by an arm weakness test. It requires a physician who understands brainstem anatomy to be recognized, or a senior and family member who know what to look for and describe it specifically and clearly to the emergency team. Sign number 2, sudden difficulty swallowing, choking on liquids, or loss of the voice. The brainstem stroke signs that begin in the throat. An older adult at the dinner table suddenly unable to swallow a sip of water without it going the wrong way, coughing, choking, the liquid seeming to enter the airway rather than the esophagus. The same older adult, 10 minutes later, speaking and finding their voice has become hoarse and strained, as though speaking through a throat that is partially paralyzed. An older adult who cannot produce the normal gag reflex when touching the back of the throat, the gagging that normally occurs automatically from that contact simply not happening. These signs, dysphagia, dysphonia, and absent gag reflex all occurring together suddenly, are the signs of nucleus ambiguous involvement in a brainstem stroke. The nucleus ambiguous in the medulla oblongata controls the motor function of the muscles of swallowing and voicing, specifically the muscles of the pharynx, the soft palate, and the vocal cords. When a stroke damages the nucleus ambiguous, or its outgoing nerve fibers, the ipsilateral pharynx and soft palate weaken. The soft palate droops on the affected side, and the uvula deviates toward the normal side. Dysphagia is the most common symptom of Wallenberg syndrome, according to the Stat-Pearls review, present in the vast majority of cases. A 2025 prospective study using high-resolution swallowing evaluation specifically in medullary strokes found severe pharyngeal sensory loss and delayed swallow initiation in these patients. The significance for seniors is not merely the immediate danger of choking, it is the aspiration risk. When the swallowing reflex is impaired by brainstem stroke, liquids and food can silently enter the lungs with each swallowing attempt, causing aspiration pneumonia in the days following the stroke. Aspiration pneumonia is one of the primary causes of death in brainstem stroke survivors, and it begins during the first meals after the stroke if dysphagia is not identified and managed. Any senior who develops sudden difficulty swallowing, sudden hoarseness, or a voice that has become weak or strained, particularly alongside any other sign on this list, needs same-day emergency evaluation with specific mention of the swallowing problem to the treating team. Sign number 1. Sudden loss of consciousness, quadriplegia, or locked-in state. The signs that brainstem stroke has reached its most severe form. The most severe form of brainstem stroke, basilar artery occlusion, can progress within minutes to hours, from the mild and easily dismissed early symptoms described on this list, to complete loss of consciousness, quadriplegia, coma, and a condition called locked-in syndrome, a state in which the person is fully conscious and aware, but cannot move any part of the body except for vertical eye movements and blinking. Jean-Dominique Bauby, the editor of Elle magazine, who became famous for dictating a memoir by blinking one eye letter by letter after a basilar artery stroke, is the most well-known person to survive locked-in syndrome. Most people who develop basilar artery occlusion without prompt treatment do not survive long enough to dictate anything. According to the Stat Pearl's review of basilar artery occlusion, the condition carries historically high mortality, exceeding 85% without timely treatment, and rapid impairment of consciousness, accompanied by brainstem signs, is the clinical hallmark of the condition. A senior who was mildly dizzy and had trouble swallowing at 10 a.m. and by noon is unresponsive and cannot move either arm is experiencing basilar artery occlusion progression. The Frontiers in Neurology review on posterior circulation stroke diagnosis specifically notes that the stuttering and progressive course of symptoms, with the stroke worsening over hours or days, is characteristic of basilar artery disease, as up to 50% of patients experience transient ischemic attacks or a waxing and waning course for several days to weeks before the complete occlusion. The emergency response to the signs of severe brainstem stroke, loss of consciousness, inability to move limbs, or locked-in state with intact eye movement is calling emergency services immediately and describing the preceding signs: sudden dizziness, nausea and vomiting with hiccups, slurred speech, swallowing difficulty, one-sided eye droop. The treatment window for basilar artery occlusion with endovascular thrombectomy is time-dependent. Outcomes improve measurably with earlier intervention. Emergency CT angiography can visualize the basilar artery occlusion within seconds of imaging. Brain CT without contrast. The standard initial emergency scan does not show brainstem strokes reliably, meaning a normal initial CT in a patient with clear posterior stroke signs requires immediate MRI and CT angiography, not reassurance. Any senior who has experienced even one of the 9 signs on this list in the hours preceding a sudden loss of consciousness needs emergency services told the complete story from the beginning, because the preceding signs provide the diagnostic context that identifies this as a brainstem stroke. Here is the complete 9-sign framework for brainstem stroke recognition in seniors. Sudden severe vertigo and dizziness, lasting more than 1 hour, or in a senior with hypertension, diabetes, or other vascular risk factors, lasting more than minutes. Sudden loss of coordination and balance, drifting consistently toward one side while walking, or one hand missing targets it would normally hit. Double vision, eye misalignment, or rhythmic involuntary eye movements arriving suddenly and not clearing. Slurred speech without facial droop or arm weakness, the posterior stroke presentation that scores near 0 on FAST, but may be the beginning of basilar artery occlusion. Unstoppable nausea, vomiting, and simultaneous hiccups. The brainstem GI emergency visible in this video's thumbnail, requiring immediate emergency contact, not antiemetics and rest. A drooping eyelid, smaller pupil, and dry skin, all on the same side of the face, Horner syndrome from lateral medullary stroke. Tingling numbness on one side of the face and the opposite side of the body simultaneously, crossed sensory loss, virtually diagnostic of a brainstem lesion. Sudden difficulty swallowing, sudden hoarseness, or inability to gag, nucleus ambiguous involvement requiring urgent swallowing assessment. And sudden loss of consciousness, inability to move limbs, or locked-in state, basilar artery occlusion, requiring immediate emergency services contact with a complete account of the preceding symptoms. The specific action for any senior or family member: know these 9 signs, write them down, and keep this list accessible in the phone, on the refrigerator, or in the wallet. Share it with every person who spends regular time with you, because in brainstem stroke, the most important person is often not the patient, but the person standing next to them, who can speak when the patient cannot. The standard FAST test will miss most of the 9 signs on this list. The standard emergency CT without contrast will miss the brainstem stroke. A normal CT does not mean there is no stroke. The 2 things that must not be missed are the time. Every minute of brainstem ischemia without treatment produces irreversible damage to structures that control breathing, heartbeat, consciousness, and movement, and the specific words to use when speaking to emergency personnel: posterior circulation stroke, brainstem, and the full list of symptoms that were present in the hours before arrival. A neurologist who hears those words will order CT angiography and MRI immediately. An emergency room that hears only dizziness and vomiting will order antiemetics and electrolytes and a discharge paper. The difference in outcome between those two responses in basilar artery occlusion is survival. Watch the next video on screen right now.